Hello, everyone. Thank you, UNESCO and the AI for AI community for this opportunity. My name is Matias Karlsson from Data in Latin America and the Caribbean. My thesis for this presentation in one line. If you are not in the data, you are not in the decision. In medicine, fairness isn't a feature. Fairness is safety. But why equity equals safety in medicine? Let's talk about this. AI already influences triage, diagnosis, and care pathways. Average accuracy can look great and still leave some groups behind. We must ask, at the operating point we deploy, who is actually protected? Two concepts to hold: false negative rate, missing disease, and calibration, how predicted risk maps to real outcome in each subgroup. I would like to show you a couple of examples where this is a problem with medicine and AI. Our first one is a chest X-ray case, and some peer-reviewed studies shows that state-of-the-art computer vision models underdiagnosed underserved groups with higher risk miss rates from Hispanic women in chest X-ray tasks. A misfinding can delay care and worsen outcomes. Why this happens? Underrepresentation in training, differences in image acquisition or devices, label noise from automated report extraction, technical parameters in acquisition and processing can shift fairness as well. What can we do about this? Vendors must report subgroup false negative rates. Also, they should document acquisition factors and audit how pre-processing shift fairness. The big problem of Latin America's health data in the world are a lot, but these are three of the most important. First one is the population. We have a majority of population. We have a big population, like 662 million people, but less than 1% of GDP is invested in research and development. Also, in Latin America and Caribbean, the average is 0.62%, far below the region spending, which is 2 or 2.5%. There's another problem, and there's an English dominant knowledge base. Nearly 84% of PubMed Medline citations are in English, which means Spanish and Portuguese evidence is vastly underrepresented in the corpora that many medical AI ingest. Even recent analysis echoes this dominance, like 86 or 87%. There's a third problem, big problem, a big genomic gap. Latin America only accounts for 0.38% of participation in genome-wide association studies, limiting downstream precision medicine models for our population. So if we think about this, when global models are trained on English language papers, European ancestry genomes, and imaging from well-equipped hospitals, maybe Latin American and Caribbean patients are statistically absent from that learning signal. Let's see another case. A celebrated risk model validated out of domain show only moderate performance in Mexican women, with variation by mammography vendor models. So we can think that models don't travel well without local data and fine-tuning. We need to validate on our patients and our hardware before clinical use. Also, we need to publish subgroup metrics and device-specific performance if we want to use it in Latin America and Caribbean people. So what these two cases that we have seen teach us, there are many more cases, I just gathered two specific cases. It teaches that the sources of harm span measurement, sensors, imaging, objective choice, data distribution, and operations. So average accuracy is not enough. Equity must be engineered, measured, and governed. So what can we ask our vendor, like a checklist, to demand from their models? So first of all, we need them to publish a data sheet with population composition, including Hispanic, Latino, etc., geography, devices used, and also known gaps. We should also ask to publish a model card with metrics by subgroup, by device site, false negative rate, false positive rate, everything, calibration, thresholds, everything that we should know about the models. Last but not least, the local validation. Demonstrate performance on our population and on our hardware before deployment. Mirai, the case that we have seen of mammography, shows why. So, as an operation fairness, what we should do before deploying is subgroup audits and threshold settings. And after deployment, we should have monitor drift and case mix changes, enable independent audits, and also define escalation paths when inequities are detected. Latin America must be in the datasets and in the validation loops. There is no question about that. We need ethical, privacy-preserving representative health data infrastructure, so models reflect our epidemiology, our devices, and also our people. I would like to leave you with three takeaways about my presentation. The first one, if you are not in the data, you are not in the diagnosis. This is important to see. The second one, fairness, is safety in medicine. This is a synonym. The last one, models don't travel well. Demand local validation and subgroup metrics. So I want to thank you all. I am Matias Karlsson from Chromodata. Let's make representation a right in medical AI. Thank you.